Welcome to the NCS podcast. We're back, and this is the NCS podcast Masterclass. I'm Dr. Stefan Mayer. I'm a past president of NCS, and I'm currently an academic neurointensivist at Westchester Medical Center Health Network in Greater New York. And with me is my co-host.
Hello, everybody. This is John Rosenberg. I'm a neurointensivist at Westchester Medical Center as well. It's a pleasure to speak with you all again. We have a very special guest today. I read many of her papers when I was in fellowship. I'll let you do the introduction, Stefan, but it's really excited to talk with her today.
Yeah. So our guest today is Dr. Chiara Roba, MD, PhD. She's a giant in the field of neurocritical care and really making an important impact. She's a consultant in neurological and general intensive care at, I'm going to butcher this, Policlinico San Martino in Genoa. How did I do, Chiara?
Perfect.
Okay. Yeah, she worked for many years with the Cambridge group, famous for studying brain autoregulation, intracranial pressure issues, the developers of the ICM Plus software. She got her PhD in neuroscience under the supervision of Professor Marek Sonika. I think I got that. And today, what we want to talk with you about, Chiara, is this very interesting concept of brain protective ventilation. After years of hearing about lung protective ventilation, I personally think this is just a brilliant concept. So many interesting angles to this. And just like to start out by asking you, where did this come from? How did you develop these ideas in this new field of inquiry in our field?
Thank you, Stefan. Thank you, John. And first of all, thank you to all the people who are listening, and thank you for inviting me. So, how did I start to think about brain protective ventilation? I think it was a progressive process because, I come from the school of Professor Paolo Pelosi. So he was the king of lung protective ventilation in non-brain injured patients. And then I trained with the group of Cambridge, who are super focused and super good on the brain. And so I think I have put together these two factors. And I think that working day by day, what I have realized is that brain injured patients are different from other patients in terms of ventilation. They have more complications and they are much more fragile. So we have to be much more precise in the setting of mechanical ventilation because they are themselves causes of secondary brain damage. What people say, at least in Italy, is that neurointensivists are not good in ventilation. But what I think is that neurointensivists must be even better than general ICU physicians in ventilation because they don't have only one organ to protect. They have two organs to protect. Three with a heart, I would say.
Love it. Yeah, I love it. You wrote you and your group, I think you've written a number of great papers sort of looking at various aspects of ventilation, how it might affect the brain, including hyperoxia, managing pressures, managing PEEP and driving pressure, the idea of permissive hypercapnia maybe sometimes to promote blood flow, maybe the ability to go very aggressively with hyperventilation for brain hyperemia conditions using brain oxygen monitoring and a variety of other topics. Out of these, which one or which couple of them do you think are the ones you really want to emphasize to our audience as being really off the starting block? What should you be thinking about when you've got someone with a swollen brain, ICP issues, obviously being ventilated?
So one of the aspects that I think are very interesting, or at least I think have really changed in terms of practice, is the PEEP. So Traditionally, brain-injured patients were ventilated with a very low PEEP because there was the fear of reducing the venous outflow because of the increased positive hand expiratory pressure. And so we started to think physiologically about it, and we started to do some studies. First of all, one point is that the lower is the PEEP, and very often it was used a zero of PEEP, a zip. But this was very often mostly correlated with the development of pulmonary complication itself. So this is a problem in terms of the lung. But then I realized that even for the brain, too low PEEP are not good. Because at the end of the story, if you see some physiological papers with CT segmentation and quantitative CT of the lung, if you set a PEEP which is enough to create recruitment without causing hyperdistension, and so you improve the compliance without hemodynamic instability, that PEEP is right. It's not too high, it's not too low. And generally, this type of PEEP is what you should use in the general ICU population, because it's the PEEP which allows you to improve the compliance and therefore does not affect the venous outflow. So this is something that I think is changed over the years, because if you look at studies from the early of 20 years ago, like 30% of brain injured patients were ventilated with ZIP. Now, the VentiBrain study, which are the most recent observational study that we published some weeks ago, the result is that 0.9% of the patients are ventilated with ZIP. So I think this has been one of the major changes in mechanical ventilation.
Yeah, that's very interesting. PEEP, an important starting point. What are you titrating against them when you're titrating a PEEP level? Like what are the physiologic parameters that you're really keeping your eye on when you're in the room twirling the dials?
So what I do, to me, the main parameters are the lung compliance, so the effect of PEEP on tidal volume and on the plateau pressures, and of course the arterial blood gas. Then you, of course, you know that there are different methods like the PV tool, which has some limitations, but many people use it. We do use it in my unit, but are the ventilatory mechanics, which together with the effect on neuromonitoring techniques allow me to set the right PEEP. Now there are also novelties in the individualization of PEEP, which I think are promising, like the AIT. In non-brain injured patients has demonstrated a nice ability to individualize the PEEP. In brain-injured patients, there is just one small study which showed promising results. We are conducting now a study on this, and let's see, it's promising. It allows you to see which are the areas that are aerated, hyperaerated, hyperinflated, or with atelectasia. So potentially can be useful in this population.
And you said that's called AID?
AIT.
And what does that stand for our audience, please?
Electroimpedensometry.
Oh, so very sophisticated. So you're getting you're giving equal weighting to the brain and the lungs here. You're probably thinking about lung health a lot more than maybe some neurointensivists might. Like, well, if the SAT's 95, I guess, you know.
So for this point regarding the SATs and the oxygenation, I think that we have been very, very scared, rightly, I'm saying, from very famous papers from Randall Chestnut, etc., which have demonstrated to all of the world that hypoxemia is one of the major causes of secondary brain damage, which is absolutely true. I think that somehow, as a result of this, especially in the very early phases, the result is that we increase very much the FiO2 because we are scared about instability and the saturation. What I think we are learning now is that we have probably to be more cautious in this, because even hyperoxemia has shown to have a potential detrimental effect on the brain, which is probably more a dose effect, but it's clear, and it's clear in many population, in cardiac arrest population, in brain injured population, because basically hyperoxemia can cause the release of ROS and increase the inflammation that we know is one of the major determinant in acute, subacute, but also chronic disease of brain injury. And now there are a number of studies which demonstrate a strong effect of hyperoxemia on the brain. The real problem to me is how we define the hyperoxemia. So which is the level of hyperoxemia that we think is dangerous. When we wrote the guidelines some years ago, we didn't find important defined thresholds. There were not huge randomized control trial on this, and we set a higher level of 120. Then we performed some sub-analysis of large databases and building a U-shaped curve associated with mortality. We found a higher threshold of 190 millimeters of mercury of PaO2. But this has to be demonstrated because these are observational studies. We need the randomized control trial which demonstrate this. And the same for other type of population, cardiac arrest is the same. There are in cardiac arrest some randomized control trial on different target of oxygenation. Some of the majority of these were negative trials, because I think that the problem is really to find the right threshold. However, just to keep in mind the concept that hypoxemia is very bad, but this should not result in an increase of FiO2 100% to the patients, because this can be bad as well.
One question that I have, Dr. Roba, talk to me a little about tidal volume. It's a question I get a lot, and I've kind of my own way of thinking about it, my own way I answer my fellows. But talk to me a little about tidal volume in brain injury patients. How do you set the tidal volume? And are there any, do you still like to go by the 6 to 8 cc's per kilogram, or tell me how you think about tidal volume in both, I would say in both a patient who maybe doesn't have acute lung injury, but also a patient who you're concerned is developing acute lung injury ARDS physiology.
Yeah. So this is a very good point, because if you read the Venti brain study, so when we had the results of the Venti brain studies, many patients, well-clean data, so we were not scared about bias or outliers, etc. And what we found was that there is an association between mortality and increased plateau pressure, peak pressure, driving pressure, but an inverse relationship with tidal volume. This was a bit surprising to us, because this would say that higher tidal volume is associated with lower mortality, which doesn't really make sense compared to the randomized control trial that we know. But because of this, we started to think and we had a look at the data. The median tidal volume in this population was very low. It was like 6 ml per kilo predicted body weight, and we are talking about in the majority of patients of healthy lungs. So probably the concept that we have got from the brain study is that the protective thing is the effect of the tidal volume on the plateau pressure, on the driving pressure, on the mechanical power, is not just the tidal volume per se. So especially in brain injured patients where you have to control the CO2, for instance, very closely, as long as the plateau pressure is fine and is protective, if you have to choose between 6 and 8, I will choose 8, keeping a protective pressure in ventilation, because I am able to control better the CO2 without increasing too much the respiratory rate that we know is part of the mechanical power and therefore creates workload to the lung, and in fact is strongly associated with the mortality as well. So this is my take-home message from the data of VentiBrain, and this is what we do. So we set the tidal. We mainly use, it's very rare that we use volume control ventilation in the acute phase. We, as a school, the Italian school of Gattinoni, Pelosi, etc., we generally use PCMV as first mechanical
pressure control?
Yeah, pressure controlled ventilation.
Yeah,
Yes.
yeah.
And we set the tidal volume based on the plateau pressure that we want to achieve.
Okay.
And if somebody really has a pure hit to the brain, like a isolated severe TBI, normal lungs, at least to start, would you sometimes even go up to higher tidal volumes or above 8, or do you like to keep everyone in that range?
Generally, we don't go too much above 8 of tidal volume as long as there is not the need, for instance, to hyperventilate the patient or we have other type of issues. Very rarely we go above that, but generally we stick on 8.
Yeah. So if I got what you just said, though, you feel that these high ventilatory rates that we dial up on these mandatory modes, that causes some form of mechanical biotrauma to the lungs.
Yeah. So I think that the concept of mechanical power, which is related to the respiratory rate, regardless then all the discussion about the different formulas, to me is a physiological concept that is very important. So initially we focused on the volume, then we started to focus on the pressures. Then now we start to focus on the work that we give to the lung. And of course, the work that we give to the lung is related to many parameters. Is related to the PEEP, to the plateau pressure, and also to the respiratory rate, which is one of the major forces, which then is related to the inflammatory cascade that we know is in experimental study one of the bases of the brain-lung crosstalk. No, so the non-protective ventilation causes itself a damage to the brain because there is a release of inflammatory mediators, which cause a feedback system between the lung and the brain. So to me, this concept is very important, regardless the type of formula that you use. For instance, there are also other formulas that have been proposed. I don't know if you remember the very good paper of Costa some years ago on Blue Journal in a ERDS patient, and he found a new formula which was much strongly associated with outcome with any other of the ventilatory parameters. And this formula was a combining between driving pressure and respiratory rate. And it was even stronger than the mechanical power. And we tested this formula in a cohort of cardiac arrest patients, mechanically ventilated, and we had the same results. It was even much stronger than the mechanical power. So I think that this concept of work related to the lung in terms of be protective is very physiological in my view.
Hmm. Hmm. So talk just a little bit about Venti Brain. It for our listeners, it was a large international survey looking at practices related, what are people doing out there in the real world? So very descriptive, very relevant, pragmatic. Based on looking at all that data, obviously, do you get any message out of there about what is the most common mistake, or maybe some of the most common mistakes or practices that should be avoided that we need to be aware of? You're smiling.
This
You
is
got an
a
hour?
tricky
No.
question. So I was happily surprised to see how much mechanical ventilator practice has changed over the years. And I was happily surprised to see how much protective has become mechanical ventilation in brain injured patients over the last years. Again, if you think that the median tidal volume was around 6 in a healthy lung population, I think it's very, very low. I use a higher tidal volume, for instance. I was
Okay,
happy.
you'll cause inflammatory release and you'll cause propofol release if you keep that healthy person at 6 cc's.
Yeah, driving pressure, mechanical power, they were all very, very protective. And they were very protective even in case of increased ICP. So this made me think that now physicians, if they want to treat ICP, they don't use too much the ventilatory setting and the CO2 values. They probably use other type of strategies because the ventilatory settings didn't change at all in our population in case of presence of not presence of ICP. This to me is something that probably can be discussed and taken in consideration, and probably something on which we have to work. Because probably physicians are a bit scared too much about the use of low CO2 in brain injured patients, which is fair because there are nice physiological study which demonstrates the fact that too low CO2 can cause cerebral ischemia. But the target that are recommended, for instance, by the Seattle algorithm, which are 35, 38 as tier 1 and 32, 35 as tier 2, they seem to be quite safe, physiologically speaking. And we also did a sub-analysis of a NEO study published on ICM last year, which demonstrated a U-shaped curve where in TBI patients, the lower limit was around 32. So I think that below 32, it becomes scary. It becomes very dangerous. But we should not be too much scared to use CO2 to manipulate the ICP within these limits. I don't know what is your practice, but we tend to
Sure.
do exactly this.
I can tell you I mean, that's just like I can tell you my practice. So basically if someone I often get this question a lot, what CO2 should we target? What, pH, and to me it's similar. I take a very individualistic approach, like you said. I always follow the guideline. I try and optimize my driving pressure, my plateau pressure, and if I'm not concerned, I have a monitor. And then to me, I'm okay driving, I'm okay with permissive hypercapnia to the extent that I feel I'm not affecting the intracranial pressure. And I think that's as long as that's to me the crutch. If I'm not concerned, and I'm curious if you practice the same way, because sometimes I don't know, or if the brain physiology is concerning to me, that putting permissive hypercapnia could lead to deleterious outcomes. And I usually put a monitor. I kind of put everything together and help that guide my therapy. What about you, Stefan?
Yeah, I was going to say the same thing, John. Absolutely. I mean, we love to generalize and make general rules, and that's fine as starting points, but everybody's different. And I think that
Yeah.
I've found, for instance, some instances of severe sustained brain hyperemia where we're trying everything, CPP optimization, bolus osmotic therapy. Then we'll go and we'll do a course of aggressive hyperventilation to PCO2 levels that would sound scary, like in the high 20s. But if you have a brain tissue oxygen monitor, and you could use a jugular bulb sat as well, though I like the PBTO2, you can trend that. And if you show that if you can drive down to CO2, get the ICP down, get the CPP up, and maintain your optimal or best possible PBTO2, that's okay in my book. And that's something that I encountered that, I kind of, my patients teach me, I always say. And I figure, well, this seems to be working the best for this particular individual. And the index case for me was this widely disseminated toxoplasma encephalitis. And the ICPs were 40 and nothing was working, and that seemed to work. It also taught me the classic dictum in a normal brain when you hyperventilate, that vasoconstriction, we're all taught, wears off fairly quickly. But in this individual, it worked for days and days and days. So
One
everyone's
question I had,
different.
Dr. Roba. What pH versus PCO2? Let's say someone is very, let's say they're compensated. They have a metabolic acidosis. Maybe they got a lot of hypertonic saline. They have a non-GAB acidosis, so they have a PCO2 of 25, but a normal pH. How do you think about optimizing PCO2, or do you really focus on the pH? Talk to me a little bit about that.
So the effect on the brain is double, is mediated by the pH, and is mainly the pH of a CSF. So you don't always have the possibility to measure it, except if you have an EVD and you do serial gases. and there is also a direct effect on CO2. So because the effect is double, and because you cannot really monitor the physiological target of this, you have to rely on arterial blood gases, pH and CO2. In brain injured patients, what drives me in these cases when I have doubt is the multimodal monitoring. So, for instance, of course, if I want to increase the perfusion, I can leave the CO2 going up, but you need to be careful about the ICP. Very, very often we use the transcranial Doppler to see how the cerebral blood flow is, and we titrate the CO2 according to the transcranial Doppler. Also because we have a lot of COPD patients where the trigger and the autoregulation between CO2, pH, and cerebrovascular activity is much impaired. And what I have learned day by day working with these patients, because in my region we have the elderly median age of all Italy, so we have a lot of COPD, is that really cerebral vascular reactivity is importantly individualized, and you really need to use the neuromonitoring if you want to set the right one to give perfusion without causing hyperemia or hypoperfusion.
So both pH and PCO2 will interact, and it also depends on the patient's autoregulatory status. It's not as simple as I thought.
No, no. And then, of course, when CO2 changes, the autoregulatory curve changes a lot. There is, it becomes,
PRX. Yeah.
yes, PRX.
I read your papers.
Well, yeah, go ahead.
Oh, another quick question. So one thing I've kind of been playing with the last year or two, TCAV, APRV, I find I have had some success with it in brain injured patients, lung injured patients, and I like that. It actually helps me really think about the lungs and understanding like where we are, the compliance, where we are with relation to FRC. And I'm curious, do you trial this mode at all? And I mean, there's been certain populations I've had success with, but I was wondering if you could give us your take and your experience.
So in Italy, this is not a very popular type of ventilation because, again, we come from the school of Gattinoni. So generally, our way of winning patients is from pressure control ventilation to BPAP, which is quite similar to APRV, and then pressure support. There are not huge evidence on APRV, and even in the general ICU population, the problem, I think, of the evidence that we have is the definition of the targets and the settings of APRV. However, I use it when I really have bad lungs and I want to be super precise and protective with the brain, because at the end, APRV is a pressure controlled with an inverse ventilation strategy. So it's like having a continuous positive airway pressure where there are intermittent time cycled release of lower pressure. So this can encourage the spontaneous breathing of the patients, which is very important for the diaphragmatic function. And this improves a lot in the experience that I have, the oxygenation without being aggressive of the lung. So being really, really protective. So we don't use it very often because I think that quite often with the BPAP, we sort out many of these conditions, but when I am very desperate,
Same here.
Same with me. Same with me. Yeah.
Same with you.
You pull it out of the tool belt, right? When when you're encountering a problematic patient.
It's a desperate mechanical ventilation.
Well, believe it or not, everyone, it's been about a half an hour. What a delightful talk. Thank you so much again.
One more question. So if my
Sure.
wife and I return to Italy, like if we come visit, we can hang out. Like I can ask you some more questions and stuff.
You gotta go out to a cafe, get an espresso.
My wife and we got engaged in Italy and we want to return. So if I come back to Italy, we can hang out, right? I can ask you some more questions.
Absolutely.
Okay.
Absolutely. And my husband and I will come to New York in November because he's doing the marathon.
Oh,
Okay.
okay.
I'm gonna email you. I'm gonna block off some time.
Yeah, we may rope you in for a Grand Rounds lecture or something up in Valhalla. Okay, everyone. Thank you so much for listening. Dr. Roba, again, thank you so much for sharing this really, really interesting conversation with our listeners.
Thank you so much.
Thank you. It's been a true pleasure. And thank you to all the listeners. Really, thanks.
Ciao.
Ciao.
Ciao.